All right, attendees, please be advised that this meeting is being recorded. So anything said verbally, anything viewed via webcam, or anything typed in the chat can become part of the recording that is posted publicly. Please mute your phone when not speaking. I'll be displaying materials for the group, so there's no need to present your screen or share your screen. And you may need to press *6 to unmute yourself if you're on phone only. All right, I think we're all set, Dr. Gaither.
Okay, thank you very much, Shelley. I'd like to go ahead and call the meeting to order. First order of business is roll call. Shelley, can you please do roll call?
Yes. Allison Welch.
I'm here. Present.
All right. Amber Prince.
Present.
Candace Williams. Carrie Lewis. Dale Woolridge. Deborah Verkick.
Present.
Garth Gamer.
Present.
Heather Miller.
Present.
Jackie Kurtz.
Present.
James Cecilini. James Cunningham. Josh Gaither. I see you. Julie Ogdenstein.
Present.
Kimberly Larkin. Laura Smith.
Present.
Michelle Guadnola. Paul Dabrowski.
Here.
Ralph Kelly. Ray Proa.
Present.
Rebecca Harrow.
Present.
Sean Boker.
Present.
Tiffany Streever.
Present.
Tom Flanagan.
Present.
I count 15. We have quorum. Thank you.
Thank you very much. Let's first turn our attention to the attendance report in both the virtual meeting attachments and for anyone attending in person. Take a moment to review attachment 3A and the attendance report. Just a friendly reminder, if you're unable to attend 2 meetings in a row, the Bureau staff will reach out to you to ask if you wish to continue participating in this group. With that, there are 2 vacancies to fill. We are currently looking for an air ambulance representative from a premier EMS agency, an individual who focuses on quality improvement from an air ambulance company, as well as a representative from a state designated level 4 trauma center program manager. If you are an individual who meets those criteria or know an individual who would be interested in participating, please do let that individual know. Submit a letter of interest to the Bureau staff, and we will work to fill those 2 open positions. With that, let's turn to agenda item 4, the Bureau reports. I'll turn it over to Chief Garcia for the first department update. And I don't know if you're talking in the room, but online we can't hear you.
He said he can't hear me. How about now, Dr. Gaither?
Yep, we have you now. Thank you.
All right. Well, good morning again, Dr. Gaither and members of the TEPI committee. I will share some updates that we will touch on a little bit later in the agenda. As of right now, ADHS continues to monitor the COVID pandemic, and we expect that the end of the declaration, the emergency declaration here in the state of Arizona, is imminent. We look forward to some discussion a little bit later on the agenda related to some of the items that will be sunsetting at the end of the state emergency declaration. As we've navigated through some of the challenges related to the pandemic over the last couple years, I'd like to note that there have been some collaborative work groups that have started to form throughout the state to address the challenges that have come up. Most recently, there has been an EMS and hospital collaborative group in Maricopa County that has come together that includes hospital CMOs and several EMS agencies. These groups have come together much like the Southern region and other regions throughout the state to look at things like ambulance offload times and other opportunities to increase the safety and efficiency of our EMS and healthcare system across the state. We'll look forward to, on some other agendas today, bringing forward an ambulance offload plan that has been proposed by this EMS Healthcare Collaborative Group. It's very similar to what we've learned that the Southern region has implemented in terms of an ambulance offload plan. I want to thank all the folks that have come together, though, on those collaborative efforts to really look at opportunities to continue to improve the safety and efficiency of our system statewide. Next week, the Bureau and Maricopa County will also host a meeting aimed at discussing after action items related to the emergency declaration as that winds down. I want to touch briefly on the fact that we know that we are in legislative session. The Bureau of EMS continues to track a handful of bills with the potential to impact the EMS and trauma system. If any stakeholders have questions related to some pending legislation, please let us know, and we're happy to respond to any questions. Rulemaking does continue at this time. The air ambulance rules are making their way through the formal process, while the ground ambulance rules are still in the informal stage, and the department expects that the next ground ambulance draft rules will be available for public comment on our website within the next month or two. Looking ahead in other news, the department will host a trauma program managers and trauma medical directors workshop virtually. That will be on April 28th. I believe we have sent out a save the date for that virtual event on April 28th. And also looking ahead, we continue to monitor the EMCTs in our state to ensure that Arizona has sufficient workforce to address our EMS needs with our population growth moving forward. I believe during our education committee meeting a little bit later today, we will be highlighting some of the most recent findings from a workforce survey that was conducted with all 4 regions across the state most recently. And we recognize that addressing some of our workforce challenges moving forward in the state will, of course, require additional resources. So we look forward to additional discussion on those items. I'll transition to our next item on the agenda, which is welcoming our new Bureau staff. Most recently, we've had Antonia Gerard join the Bureau of EMS and Trauma System. She is a new rate analyst working with the CON and rates program within the Bureau. We're very fortunate to have Antonia on board. I think everybody that's participating in these meetings recognizes the challenges in terms of recruitment and hiring during this time frame, and so we're happy to welcome Antonia to the Bureau. I will pass it to Dr. Bradley next to talk about the naloxone leave behind program.
Thank you. Just doing a quick audio check. Josh, can you hear me okay?
Yes, you sound great.
All right, excellent. Thank you. So once again, we just wanted to give a big reminder to everyone regarding the naloxone leave behind program. As we'll see in some data that will be shared a little later in the meeting, we continue to see increasing rates of opioid overdoses within Arizona, and really want to look at different opportunities that EMS can help address this. One of the programs that is gaining traction throughout the United States is a naloxone leave behind program, and we have developed a process to really hopefully make this as streamlined as possible. On the agenda itself, there are hyperlinks that you can go to our website that will take you to all the information you would need if you're interested in starting this process. So this includes a training PowerPoint that can be used. In addition, there's also a pamphlet that can be customized to your jurisdiction with kind of resources available, and then a link to the ADHS site where you can apply to get free naloxone to utilize as part of the naloxone leave behind program. We do have the standing order as well for an EMS agency if you're BLS only. You can use that. That's a standing order with my name on it to get naloxone and to utilize this program. If you have any questions, please feel free to reach out to me. We really are looking to see more of these programs stood up across the state, and we'll continue to advertise. I'm happy to answer any questions that people have, and I'll put my email address in the chat box as well. All right, here are no questions. I will hand it over to Julia to discuss SHARE.
Good morning, everyone. Just a couple of updates on SHARE. As we've mentioned in previous meetings, the Bureau has been working over the last year to reflect information from the cardiac receiving centers and referral centers across the state to ensure that recognized hospitals have continued to maintain recognition requirements. And we've made some good progress on that. As of today, we've been able to recognize 35 receiving centers and 2 referral centers across the state. So just to thank you to everyone that's worked on submitting documents to the Bureau or submitting data to CEDAR. We value your participation in the program. And then just a quick reminder that CEDAR staff at the Arizona Emergency Medicine Research Center are hoping to get out the 2021 SHARE reports earlier this year. We know that the hospital data is crucial, and your efforts to get the data in early is incredibly helpful in this process. So just thank you again to everyone that's participated in that. That's all. And I will pass on to Adam for EMS for Children updates.
Hello, good morning, everybody. Just a couple of updates. Our EMS survey is moving along nicely. We have better than last year's numbers, and we still have some time to go on it, so we're excited about that. Our 5th year of funding is, we just received word yesterday that our 5th year of funding is going to be coming through in the next few months, so that's great. And in response to our ACEs action plan, the 3 goals that ACEs has is to reduce the number of ACEs, adverse childhood experiences, to characterize the data that shows Arizona as being 50 out of 50 for adverse childhood experiences, and also to mitigate the number of adverse health outcomes associated with these ACEs. And so in response to that, the Bureau has developed an online training tool for EMS agencies that can be found in our education page, and I will put my email in there for anybody who wants to follow up, for anybody who has follow-up questions to that. If nobody has any questions, I'll pass it to Ann. Ann, are you around?
Yep, I just wanted to make sure nobody had any questions before I started. So I'm just going to give a quick update. I'll be back later on in the agenda on version 3.5 for AZ Peers, which is the new NMSIS format that all states have to go to. So a new data dictionary should be out fairly soon, I would say in the next month. I just closed the survey that was sent out to all primary contacts at all EMS agencies and any hospitals that were on our list for them to give any feedback regarding any of the changes. So right now I'm kind of addressing any comments that I found in that. And the big thing is we've moved the transition deadline. Can I share my screen for a second? Thank you. Hopefully you guys can see this. I know it's a little small. We have moved the transition to 3.5 deadlines out by 6 months. And this is posted on our website right now so that if anybody goes and refers to it, it's updated there also. So we anticipate to be able to accept 3.5 by the beginning of July 2022. And so we are moving the transition deadline to transition from 3.4 to 3.5 for all EMS agencies submitting data to July 1st, 2023. We would love it if people could, transition as soon as they're comfortable with doing it, but 6 months just didn't seem like enough time for everyone to be able to do that. And vendors are at different points right now in their product development. So that's it for the 3.5 update. Does anybody have any questions? Okay. Thank you.
Okay, thank you very much. I think that ends our updates for from the Bureau for today. Let's turn our attention then to, sorry, get the, Shelley, if you don't mind pulling, there we go, the agenda back up. I just can't have the agenda open and the meeting window open at the same time, so thank you. Now let's turn our attention to updates from our standing groups. First, the Trauma Registry user group. Kimberly, are you on the phone? I think I saw you. Maybe not.
I can give an update. This is Carissa Wilson. It doesn't look like Kim's here.
Perfect.
So for our last meeting, we reviewed the new 2022 ASTR data dictionary. So there were 2 changes that were made just to reflect the new NTDB data dictionary. So now under procedures done in the hospital, registrars will be collecting plain radiography of the whole body as well. Before it was just kind of CTs and ultrasounds and that kind of thing. And now for hospital complications, the option for extremity compartment syndrome is retired, so they will no longer be collecting that. We also talked about the AZ Peers ASTR linkage, and that is working. There haven't been any issues, so registrars can use that and link the run sheets to the trauma records in ASTR. So I think those are the 2 big updates.
Excellent. It's exciting to hear that that linkage is working well. Thank you for the update. Next, let's turn to Heather for the Trauma Program Manager workshops.
Can you guys hear me? I'm sorry.
Yes.
Okay. So for Trauma Program Manager, we had our meeting February 24th. Pretty good attendance. We had the Arizona Trauma Association speak a little bit there. The Center of Rural Health has updated the email listserv to a different listserv, and we discussed a little bit of updating some of the protocols that are on the outbox for people to reference. Other than that, there was just a lot of discussion on some changes and what's going on, and the state updated us on the remote redesignations and what to expect with stuff like that. So that was primarily our meeting.
Perfect. Thank you very much. Next then, Ray for the EMS Registry user groups.
Hey, Dr. Gaither. Yeah, I apologize for missing the November meeting. It was a little busy here. Just was going to echo kind of what Ann had said about the 3.5. I know she just closed out the 3.5 survey. I believe it was on the 9th of March. So that's going to be coming out. As far as that, I wasn't aware of a registry meeting. If I missed it, I missed it. I know I tried to reach out to her a little late. So if she has anything else to add on that, that's all I had.
No, we didn't have a meeting, but thank you, Ray.
Okay, perfect.
I guess the survey was our meeting, because normally we have data dictionary meetings. Instead, we did a 2-week survey for virtual stuff. So you're right.
Okay. Let's move on then to discussion and action items. The first item up for discussion is to review and approve the meeting minutes from our last meeting. Do I have a motion to approve these minutes?
Move to approve. This is Tiffany.
Thank you, Tiffany. A second?
Second. Ray Prog.
Thank you, Ray. We'll go ahead and open this this item up for discussion then. Any request for changes or corrections to the draft meeting minutes in front of you now? Okay, looks like we've made it through the brief overview on the screen share. Hearing no requests for changes, I'd like to call for a vote. All those in favor of approving the minutes as presented, please say aye.
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 Any opposed, same sign. Any who wish to abstain? Hearing no votes and no abstentions, the motion passes. Thank you all very much. Turning back to our agenda, the next item is to accept nominations and approval for vice chair position. We do have a single nomination for vice chair, Carrie Lewis. At this time, I will obviously open it up for any other nominations. Okay, hearing no other nominations, I'd like to ask for a motion to approve Carrie as the vice chair for the TEPI committee.
This is Ray Pro. Make a motion to approve.
Thank you, Ray. I heard that motion and I did not hear who did the second.
Rebecca Haro would do the second.
Thank you, Rebecca. I'll then call for a vote. All those in favor, please say aye.
Aye.
Aye. Aye.
Thank you. Any opposed, please say nay. Any who wish to abstain, please say aye. Hearing no abstentions or no votes, we have approved Carrie for the new position as vice chair. Congratulations.
Thank you.
All right. Moving on then to our next agenda item. This is the discussion and amendment of the list of discretionary reports. And my understanding is that let me give some background, I believe, and the Bureau can feel free to jump in. We've maintained this list for about 2 to 3 years now and have never used it. So I think the question that we would like to ask is, should we continue to use this list of reports? Is that an accurate reflection from the Bureau side of this agenda item?
Yes, Josh, thank you. I think, one of the things that we recognize is that while many of these topics are very interesting topics, they aren't necessarily things that we could really run a report on when we look at data. Some of them are just too broad and not specific enough, but also recognizing that our data team is working on so many other projects on a regular basis that taking on some of these additional projects just hasn't happened. And so we really want to highlight some of the work that our data team does with Russell and Ann, who are down one person now for about coming up in 1 year. Just the amount of work that they do on a regular basis on data analysis from AZ peers and our trauma registry, and putting together both our EMS annual report and trauma annual report, in addition to several other Tableau dashboards. So we wanted to at least bring this forward to have the group discuss whether or not we wanted to potentially sunset this. We are certainly open, if the group would like to bring it forward in the future, a very specific data request for us to look at creating a report. We would really like to do that. But with these options, they're just right now, it's going to be hard for us to move forward. So rather than us continuing to project these 3 times a year, so every 4 months, wanted to bring that up for the committee for consideration.
Thank you very much, Dr. Bradley. I think in order to proceed with discussion, I'd like to ask for a motion for this agenda item. I believe the motion in front of us would be to remove this list of potential discretionary quality improvement reports as a standing agenda item for this meeting. Do I have a motion for that?
This is Garth Gamer. Yes, you do.
Thank you, Garth. A second?
This is Sean Barker. Yes.
Thank you, Sean. We'll now open this up for discussion. Any discussion on removing this as standing or sunsetting this list of discretionary reports?
Chairman Gaither, some of these I think are somewhat important to the system and might represent low-hanging fruit, like the number 11 EMS trauma scene time greater than 20 minutes. that might be fairly easily compiled. Maybe I'm just naive to what that might entail, but I'd like to, pursue that at a convenient time in the future. Thank you.
Thanks, Dr. Gamer. And this may generate a question back to the Bureau. Are trauma scene times an item that's already reported in the EMS or trauma annual report?
I am not sure on that answer, Josh. I don't know. I know Vatsal's on vacation this week. I don't know, Carissa, if you're on the line.
I don't know off the top of my head, but I can go look at the annual report. Vatsil would definitely know, but yeah, like you said, she's not here. I can look and get back to you on that.
Yeah, I didn't intend for this to in any way scuttle the main motion, but just a future item that we could maybe take up.
Yeah, very good point. Thank you, Dr. Gamer. Other discussion? Okay, it is early in the morning on this St. Patrick's Day, so there's not a lot of discussion. That's just fine. If I'll give it another 10 seconds of silence here, and then we'll go ahead and call for a vote.
Josh, just one more point. I would just keep this around somewhere as a reference document and then resurrect it from time to time just to see if there was a spirit for going at these topics piecemeal.
Thank you. I think that would probably fit well as a friendly amendment to sunset this list as a standing agenda item, but keep it in mind should there be future questions that would be of interest to the Bureau. Does that serve as a friendly amendment suitable to everyone?
Yes, I think that's a good amendment to my main motion. I'm very much accepting of that.
Okay, so this motion would be to sunset this list as a standing agenda item, maintaining it as a reference for future additions to possible annual EMS or trauma reports. Thank you again for that comment and addition. Any other comments? Okay, we'll call for a vote then on this agenda item. All those in favor, please say aye.
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 Aye. Any opposed, please say nay. Any who wish to abstain, please say aye. Hearing no abstentions or no votes, the motion passes. Let's next turn our attention to the discussion of the status of the emergency declaration. I'll turn it back over to the Bureau for discussion on this item.
All right, good morning again, Dr. Gamer. Is our audio still working?
Yep, we can hear you well.
All right. So this is the point in the agenda where we want to talk a little bit about the status of the emergency declaration with all of our stakeholders on the line. As we'd mentioned earlier, and I'm sure some of you have seen in the media, the end of the declaration here in the state of Arizona is imminent. We would expect that based on some of the COVID metrics that we are monitoring closely, that it would be perhaps not in a matter of weeks, but a matter of days. And with that, we want to make sure that we're beginning the discussions on what that means in terms of the end of some of the existing waivers and other measures that have been in place since the beginning of the emergency declaration. Some of the things that we could expect as that emergency declaration winds down here in the state would be the end of the enhanced surveillance advisory. That is all of the reporting required by hospitals, labs, and even some of the information that is shared with PSAPs regarding COVID cases. When the emergency declaration ends, the enhanced surveillance advisory will come to an end. And so what we will see is a shift from mandatory reporting over towards encouraged voluntary reporting. Some of the entities that we work closely with in terms of some of that enhanced surveillance advisory information, they do use the state as a pass-through. They report the information to our state systems, and then that is reported up to the federal entities. Again, we would encourage that some of that reporting in the enhanced surveillance advisory continues on a voluntary basis. But some of the things that you could expect would end would be the collection of negative test results, as well as adult immunization information. When the enhanced surveillance advisory ends, those are some examples of data points that we will no longer be collecting under a mandate. Another executive order that would end with the end of the emergency declaration would be the surge line. The Arizona surge line was set up in 2020, and it continues to be used as a rural transfer service currently. That would evolve with the end of the emergency declaration, and we would expect to be sharing more information with stakeholders in the coming weeks or perhaps the coming days as we learn more about what that transition of the Arizona surge line looks like. We currently have other waivers in place as well that would sunset. An example for EMS is an emergency measure that allows EMTs, all levels of EMCTs rather, to administer vaccinations and conduct viral testing. When the emergency declaration ends, that emergency measure will sunset as well. So you will be receiving communication from the Bureau in terms of waivers and emergency measures that will cease to exist when that emergency declaration goes away. I know that other things that are being contemplated right now are related to professional licensing waivers. There are a number of temporary licenses and other things that have been issued to nurses and other healthcare professionals during the pandemic. I know that there are folks that are tracking some legislation very closely that would allow some of those professional licensing waivers to remain intact through the end of the calendar year, I believe. That is something that I'm sure will come into play in terms of when the emergency declaration ends here in the state. There are some other regional protocols that may be impacted as that emergency declaration sunsets. And certainly we want to consider crisis standards of care being walked back as well. And for that, I will pass to Dr. Bradley to see if she has anything to add on those topics.
Thank you. I think we wanted to really make sure we highlighted, as we recognize we don't have a specific date when this may end, but we wanted to have people start the conversation within your regions as well as with your medical direction about what this will look like when the emergency declaration ends. As I'm sure everyone recalls, we implemented in March of 2020, so just over 2 years ago, the crisis standards of care, which included very specific EMS COVID-related guidelines. Those were a deviation from routine standards of care. So as that emergency declaration does end, crisis standards of care will end as well. So I think we wanted to make sure we highlighted that piece that all regions and EMS agencies will need to look at those kind of COVID-type guidelines to determine what they would like to do with those moving forward. So we wanted to really put that out there. We'll repeat the messaging all meetings today, but recognize that this was a substantial list at the time to create these guidelines and implement them across your system. We definitely want to get that messaging out so that you can really train your personnel and make sure that that messaging gets out to everyone. We are happy to open up any questions from that.
Dr. Bradley and Dr. Gaither, I just want to add and plug for communications from the department moving forward on the status of the emergency declaration and some of the waivers and things that will expire. We want to encourage folks to, if you have not already subscribed to Gov Delivery, that remains our primary method of communication to push out those blasts with more information. And so I just want to make sure we are plugging Gov Delivery here.
Okay, thank you, everybody for the updates. I do not believe there is any action item that needs to be taken as part of this, but certainly a good discussion item that we should all be aware of. Any questions for the Bureau regarding the walk back of the emergency declarations? Okay, hearing no questions, let's move on to the next agenda item, 6E, which is discuss current data reports. And I'll turn it over to Anne for some discussion on this item.
Thanks, Josh. Good morning, everybody. Again, I forgot to wish everybody happy St. Patrick's Day. I'm wearing my green necklace, just, you know. So I'm going to share a couple different dashboards, and just to make everybody aware for some of the things we'll discuss them briefly, and then I think there's some comments from Josh and Gail also on them. So let me first just start with actually the ADHS dashboard, just to make everyone aware of where it is, the opioid dashboard. So I already have it. I'm going to present, or you guys can't see.
I pushed the button to stop presenting.
Okay, thank you. All right, can everyone see my screen?
Yes, thank you.
Okay, great. So if you go on the main ADHS webpage and you go under, you can go several ways, but if you go under topics of opioid, and then down to dashboards, there's a lot of dashboard information here. A lot of it's updated fairly live or close to it. And you can go to EMS and law enforcement, and there are, I won't go through all this, but I want everyone to know where it is. There are a lot of dashboards that are available, information. You can sort by age group and type of response and find a lot of information here. And one reason we wanted to point this out is lately we've gotten just some requests for information, and a fair amount of them can be answered from this dashboard without having to wait for a data approval and data pull. So just be aware this is here. If someone's looking for some information, they might be able to find it here. And I'm sorry for any noise you hear in the background. I have 2 dogs and 2 kids home for spring break, so we'll see how it goes. Okay, so the next dashboard, this is in no particular order, but I just thought since I have the webpage pulled up already, I was going to talk about the update to the trauma injuries by year. So once again, if you go, you can kind of see the link of where you would go is from the homepage, preparedness, EMS and trauma system, data quality assurance, and then there is a data visualization. If you click on that, there's several dashboards in here, and one of them is the trauma injuries by year. And if you page down a little bit, it gives you all the information you can read through on what's included in this report. This is all information from the trauma centers. And kind of the highlight right now is the fact that the 2020 data has been added to this dashboard. So that's new, and if you want to click through, you can sort by region, you can isolate by the year, and there's just a lot of information also available on here, and it's really great. I mean, there's, and don't forget there's different tabs too, so you can go through the different information. It gives a lot of data. Vatzel is out this week, but she did want me to also mention that for the, let me go back to the visualizations. For the MVT, so the motor vehicle traffic related traumas, and the race ethnicity differences dashboards, these currently do not have the 2020 data added yet, but it will be added soon, I believe, within the next week or so. So check back on those for the 2020 data coming soon. Okay, and then I was going to move on to some cardiac arrest and opioid dashboards, but I just wanted to pause really quickly and see if there's any questions on what I've gone over so far.
Thanks, Ann. I'll add a plug for this. I used the dashboards about 2-3 weeks ago to generate some baseline data for a grant that we submitted at the University of Arizona, totally unrelated. But this is an incredibly valuable resource, very well done and easy to use. So great resource for anyone looking for baseline stats.
I'll pass it on to Vatzel. This is definitely
John.
Work, yeah.
And
yeah.
And this is Gail.
Mm-hmm.
one of the reasons that I really wanted to highlight all this work is I think our website we're hopefully going to go through a redesign at some point, but it is hard to find this. And so really, especially with this committee who looks at all the data, both trauma and EMS related, there is so much work that is done by Vossel and Ann to get the data from EMS and the trauma centers, to create these reports, and then also to create these dashboards. And so really you can use this data for your facilities, for your regions, your agency, to kind of look and see what's going on for things such as grant applications as well. So we really wanted to highlight some of the data that what you give us with your EMS agency when you do an EPCR and it goes to AZ peers, kind of what happens to that data. And similarly with the trauma centers, there's a lot of workload for the trauma centers to input all their trauma data into ASTR and really recognize kind of what can be done and how you can utilize this data. So we are hoping to use this committee to really gather input when you see these reports. If you can maybe pull up the opioid one again, one of the things that we recognized when we looked at some of the opioid data was there was initially the age bracket for the highest rates of opioid overdoses appeared to be unusually an elderly patient population. So that actually made us take a deep dive and look at the data and recognize that we needed to be much more specific when we pulled the data for this report, because we really want to make sure that EMS is putting that they suspect an opioid overdose. We recognize that there are some areas where EMS is giving naloxone relatively frequently in a cardiac arrest patient where they may not necessarily suspect an opioid overdose. So if you were to count that in your numbers, it would artificially elevate an older age population with opioid overdoses. And so when we look at the data, especially in this Tableau format, where you can make adjustments based on age, regions, et cetera, you can really start seeing some of those things and figure out how we can adjust our data, but also what we need to do education-wise. We want to make sure that we educate EMS that we really should be giving naloxone if we suspect an opioid overdose. I think many of us were trained back in the day where naloxone was just a routine part of the cardiac arrest algorithm, but that's really not the standard of care anymore. So without this data and looking at that data, we really can't make those changes. So we'd like to highlight some of this work, especially to this committee, get input from everyone here participating both live and virtually, and just really hope that people will kind of use these dashboards and go visit them to gather more data. So that's my sales pitch, but I'll open it up if there's any other questions on the opioid trauma-related ones. And Ann I know she is going to try to do her best. She's also somewhat on vacation, but was happy to help out today. So if there's other questions or things you guys want to see, if we want to maybe go back to the trauma one, Ann, and people can see that and see if they'd like to look at any more of that data.
Just want to make sure I'm not muted. Can you guys all still hear me? Okay. Yeah, let me just go through the tabs really quick. I won't cover every single graph, but I think, like I said, the introduction is really important. It's kind of farther down, but it gives you a lot of the information so you know what you're looking at. The 2020 data, as I said, was there. You can do by year, you can go by region. It gives you total cases by age, by county, and these are rates, race, gender. And Gail and Josh, if there's anything that you particularly want to point out, feel free to interrupt. Mechanism, trauma rate by age. And whoops, and I accidentally shrunk that, sorry about that. For the mechanism. And then we have intent. So that would be unintentional assault, self-harm, other intent, and then null values. And it gives you all of the information here on the top 5 mechanisms of trauma. Once again, it goes through the gender, basic demographic information. And finally, don't think there's another tab after this, I'll check. For the fatal trauma, gives you some nice visual graphs. And this is, I believe, this is something that you can share because it's publicly available if you feel like there's an internal group at your facility or agency that might find this interesting. And there's a repair too, which is great.
I'll give a quick plug to that end. At least for our group, we use this data to identify areas of health disparities that would be ideal targets for public health interventions. So if you are a trauma center manager or trauma center data specialist, please share this with your trauma leads as potential areas to address not only public health intervention, but peer education and outreach in the communities that you serve.
Okay, oh, look, there's more. So we have also trauma by injury and county. And there's just so much information, and you can select by county here specifically. So if you work with your public health department in your county, they might be interested if they don't know about this dashboard specifically. And once again, suspected, confirmed alcohol and drug related trauma. And once again, this is all data out of our trauma registry. The Carissa Wilson is the registry manager for, and Fossil did all this analysis. So I can probably answer some questions about this, but I will redirect most of them back to Carissa and Fossil.
Looks like Sean Boker has raised her hand.
Yes, hi. I'd like to point out a major limitation to the falls data. The state does not collect ground level fall hip fractures unless those patients have been transferred to another facility. So that is a tremendous hole in our falls data. The trauma centers that report to the National Trauma Data Bank do collect that data and send it to the National Trauma Data Bank, but the state does not collect that data. And I would strongly recommend that we begin doing that because we are not accurately tracking our fall data.
And I believe that's due to the trauma inclusion criteria. I don't know, I can't remember who sets that, if it's TEPI, Gail or Krista. Do you guys want to speak to that?
Hi, yes. So our inclusion criteria does exclude isolated hip fractures. And I believe that's written into rule. So I don't think we can change that until the rules are opened again to make edits, which I think that's a great point that you brought up that I think should probably be addressed. I'm sure that there was a reason for it when that was included. I wasn't here when that happened, so I'm not sure what the reasoning was behind that, but that is in our inclusion criteria.
Okay. Does anybody have any further questions, or did that answer your question? I mean, somewhat.
Well, it wasn't necessarily a question. It was just a statement so that anybody going to the falls data would understand the limitation of that data and would also be aware that we are not currently tracking that. And that's something that I really believe that the state should be tracking.
I think, and I mean, that's a good comment. I don't know if the inclusion criteria are listed here anywhere. We can note that.
I have it pulled up if you want me to share it. And
well, I just meant like on the dashboard, if this was
I
something
see.
that you referred to. So I'll take a note. I'm sure Shelley and Chris are too, and we'll discuss maybe adding some additional information on the registry dashboard, like a page about the inclusion criteria, so that it is more clear what is included in the overall. What cases would be entered by a trauma center in the first place. Okay. Are there any additional questions before I move on to the cardiac arrest and opioid dashboard information? All right. And please let me know if there is as we go along. So this is a dashboard, but these are static slides. It's currently internal facing, but there's some really interesting information. I'm going to go over it fairly quickly, and then I know there probably will be some questions and comments, and I think Gail and Josh may have some things to say. So some really interesting information here. This is cardiac arrest incidents by year and month. So at the bottom here, I just want to orient everybody because I know sometimes, it's by the time you figure out where all the bars are, we've moved on. So you can see just by year, but then each month. So January for the years. And obviously we've only gotten partway through March. So this is going to look a little weird. And this is not, it percent wise. So the percent of total calls that are cardiac arrest, because this is EMS data. Looks about right, but we're only partway through March. But this gives you an idea of year over year. And of course, we're always looking at 2020 as hopefully an odd outlier. Sorry. And then this is just the total number of records. It just gives you an idea how many records we're talking about, even though the top graph is a percent of the total. So that's not, like a rate. This bottom one just gives you how many records were included in this analysis. So for January of 2019, there were 77,824, but for this January of 2022, there were 92,695. And I know it's excluding things like canceled calls and false calls and a few other things. So it's only going to include when there was a patient. Okay, and then, I'm sorry, this is going, okay, cardiac arrest. So then, this is also cardiac arrest information. This is deaths. So once again, you have a percent of cardiac arrest calls over the years per month. And below it, this is actually the exact same concept. This is the transports percent of total cardiac arrests over the years. And so the main kind of thing that we saw with this is that cardiac arrest deaths have increased overall, but the transport is down. And then I just wanted to cover the same information, but now just forget cardiac arrest and think opioids. So once again, this is going to be the count of opioid incidences out of all of the EPCRs that we received by year, by month, and the percent of calls out of the total that were at least documented as opiate overdoses or suspected opiate overdoses. And let me go down. This is exactly the same numbers as what you saw in the cardiac arrest graph, where it's the total number of records. So these exactly match. It just on the same dashboard page. We just want to repeat the same information. The total records that were analyzed, so excluding canceled calls and such, are right here for this number and percent. And then the last one here, this talks about opioid-related deaths. So that were documented by EMS. So this is once again, by year and month. And you can see we have the January data, we have the February data, we have the March data. I would not look too closely at the March data yet because we're only partway through the month. And so opioid transports, where it displays the percent of opioid calls that resulted in a transport. So this is the percent of opioid calls that resulted in a death, percent of opioid calls that resulted in a transport. And we are seeing an uptick, as you could see, in opioid deaths and a down in transports. And I think that's all I really have to discuss on this dashboard. Gail or Josh, do you guys have any comments? I know you didn't get this information till pretty late. Or anybody else have any comments?
Okay, I'll start out, and Dr. Bradley may have something to add. Great data. I'll start with a question, and then I have a couple comments. My question is this data generated from linked data sets? In other words, is this AZ peers linked to the hospital discharge database or the death database? How are you getting your survival numbers from this?
No, I don't believe so. I believe this is just EMS data from AZ peers, and the cardiac arrest. I don't remember the exact inclusion, but it would go off whether or not EMS indicated as a cardiac arrest, either by primary impression or there's a cardiac arrest variable. And the deaths would be determined by, I believe that would be pronounced death by EMS. So once it goes to the hospital, we don't include those as deaths because EMS kind of their call ended when they got them there and the patient was not deceased.
Got it. Okay, thank you for that clarification. The couple notes, the first on the cardiac arrest one, it is remarkable that during 2020, we really did not see a significant increase in the rate of cardiac arrest or the rate of cardiac arrest. Other systems have reported the opposite of that, that cardiac arrest rates during 2020 as an overall percent of call volume did show a dramatic increase. So interesting from an academic perspective, at least. I think the other interesting part to me is that there's a clear increase in the rate of cardiac arrests in 2021 and 2022, which leads to the obvious question of why. And in my mind, that's people not getting the health care they need during the COVID epidemic, most likely. That would be a logical step. So interesting data from that perspective. I think I'm also encouraged to see the opiate numbers trending down after our uptick in 2020 in the COVID pandemic. Maybe not, I guess trending a little down or flat. I think we were all very concerned that COVID would result in a dramatic increase in opiate overdose. But this seems to suggest that there is a small, if any, increase in 2020. And then it looks like in 2021, mostly that increase has gone away or been flat. So that's encouraging data.
Thank you for those comments, Josh. Any other questions or comments from anyone else on the line? Like I mentioned, there's just a ton of work that is being done with all the data that's submitted by the EMS agencies and to AZ peers as well as the trauma centers. And so we really wanted to highlight some of that work and recognize, what are some of the things that we can do differently. As Dr. Gaither pointed out, I think certainly there are the downstream health effects of people not seeking preventative health care for a number of years. We also recognize that people are still delaying calling 911 and sometimes waiting longer to call 911 than they would have in the past. And so several of those factors have likely contributed to the cardiac arrest data and those increases in 2021 and 2022. 2020 was a bit of an anomaly just because we had a significant reduction in overall 911 calls where we had two big dips compared to previous years. Our typical volume that we see for 911 calls is really very stable. You see some seasonal changes that we get in Arizona, but otherwise year over year, those curves have been very stable. What we saw in 2020 were two significant dips that happened over the course of that year, and definitely that resulted in less people accessing the 911 system.
Dr. Bradley, this is Jackie Kurth in the Office of Injury and Violence Prevention. I think that the opioid slides in particular, the transport and the decrease in transport, I know for us with our efforts to distribute naloxone statewide, I think that really supports your efforts towards EMS leave behind programs because we know that the transport of patients who are having drug overdose has decreased. So I think that's a really good data point to support your efforts towards EMS leave behind, or naloxone leave behind.
Thank you, Jackie. And a big thank you to Jackie and her team. She is the one that funds all of the EMS naloxone. So when you request naloxone for your leave behind programs, that is coming from Jackie's office. So a big thank you to her and her team because they provide a lot of naloxone throughout the state of Arizona.
Looks like Sandy Nygaard has her hand raised.
I do. I just have a question. This data that we're gathering here, this is strictly from the EMS calls. Is that correct?
Yes.
Yes, I believe the opiate data would include law enforcement data also because they also report opiate overdoses. But Yeah, this is not out of any other registry besides AZFIRS.
Okay, so my other question then is, does anyone collect the data from the patients that come to the hospitals that are not transported by EMS, that end up being such as cardiac arrests and opioid overdoses?
Yes. So
okay. Sorry, Gail, go ahead.
there is when Anne showed you the main ADHS opioid webpage that has the opioid data. That is there's several mandatory reporting requirements in the state. There's the law enforcement and EMS, but the hospitals also have that mandatory data reporting. So there is a different subset of data that is specific to the hospitals for patients that are not brought in by EMS.
Okay, thank you. Yeah, I was just curious because we noticed that a lot of our EMS traffic had dropped during these periods, and patients who potentially would have called 911 were not. They were coming in by their privately owned vehicles. So I was just kind of curious. Thank you.
Thank you, Sandy. Great point to mention that. I see in the chat a statement from Dr. Gamer, and then we'll go to Bruce next. I see a statement from Dr. Gamer. If anyone's on iPhone, it will be interesting to see what happens to the number of transports when state emergency declaration ends with the resulting publicizing as such. Almost assuredly, transports would go up, I think, for Dr. Gamer. Next, Bruce, you had a question? Bruce, you are on mute if you are trying to speak.
Star 6.
While potentially he is trying to unmute his phone, is there anyone else that has any questions or comments regarding any of the data pieces?
Okay, hearing no other questions from the Bureau side, any other items to discuss with this agenda item or questions from the committee members? Okay, well, thank you for the fabulous work and great data. Thank you for sharing it with us. How can individuals access this data if they're interested in reviewing it further?
Thank you.
Yeah, go ahead, Gail.
Are you talking about item F, Josh? Just confirming.
Sorry.
Oh, discuss trauma annual report. Are you moving to the next agenda item?
I was talking about item E. So the data you just shared on the screen, is that publicly available data yet, or is that just for a brief introduction at this committee?
Go ahead, Anne.
Oh, sorry. Yeah, so that dashboard is currently internal. I don't know as to the plans to have it ever external facing, and I'm not aware. I'm not sure. Batzel probably knows. I believe that data that we just displayed may be included in the minutes because we showed it at the meeting. But as far as an interactive dashboard, it's not yet publicly available.
Okay, thanks very much. We'll move on then to the final agenda item, discuss the trauma annual report. And again, I'll turn it back over to the Bureau to lead the discussion on this item.
Thank you, Dr. Gaither. So we wanted to just start the discussion. The trauma annual report and EMS annual report, we typically present near the end of the calendar year, but really those take several months to develop. And so before Batzel and Anne start working on that next report, we wanted to just talk about that report. We have historically had year-over-year data and really looking at how the trauma system has evolved over the past decade in Arizona. So one of the things to potentially consider that we wanted to bring up and see the interest from this group is do we start splitting up some of our trauma data into different categories based on the trauma center level, recognizing kind of to what Sean's statement was regarding a ground level fall with a hip fracture. Those patients may be a trauma activation at a level 4 facility, where if they go to a community ED, they would not fall into our trauma bucket. But also recognizing that the patient population that goes to a level 1 trauma center, especially in the large metropolitan regions, is very different than a patient population that would go to a level 4 or a level 3. And so do we start looking at part of our report, potentially making some adjustments where we separate out our trauma patients based on whether or not they went to a level 1 versus a level 3/4 trauma center. So I wanted to start that conversation and just get some input from this committee. We recognize we do have quite a bit of participation from multiple trauma centers on the committee, and this body really feeds into STAB. So wanted to open this as a discussion point for the group.
This is Tiffany. Dr. Bradley, I think that would be really helpful so that you could look at almost like versus like, right? What are our rural facilities getting versus what are our metropolitan? And what are our level 1s seeing versus our level 4s? And it also gives you an opportunity to see, you know, are we sending our trauma patients to the right places? And looking at some of that. And so I think that would be valuable information, at least from a level 1 perspective.
Thank you, Tiffany.
This is Sean. I also agree with Tiffany. And I think you're going to see some interesting changes because you have not all level 4s are the same. Some level 4s are very critical access, limited resources. Other level 4s are more enhanced, some with orthopedic services. And I think during the pandemic, when we had bed limitations, you had some critical access level 4s sending patients to other level 4s, but the level 4 they sent to was one that had greater resources such as orthopedics or an ICU. So I think it's going to be very interesting to break that data down.
Thank you, Sean.
Gail, this is Paul Nebraska. I have a question. Are you thinking of doing different reports for different groups, or is it just going to be one big report that has more information kind of broken down by perhaps trauma center level?
Great question. I think that's part of the discussion of what we want to do moving forward is, you know, do we want to create totally separate reports, or do we create a single report with kind of separate buckets with some combined data and some individualized data based on the level of trauma centers? So I think there's different options. One of the things I wanted to bring up is there an appetite to change the report? Number one is the first question. And then looking at that as probably being our first break point, which is to try to look at certain parts of our trauma annual report and separate out that patient by trauma center level.
Sure, and I think certainly things that happen in level 4s are very interesting to level 4s and level 1s that oftentimes receive those patients in transfer and things. So I think, regardless if it's in the same report or different reports, there will be information that's pertinent for the for level 1s, even if it's a level 4 type of patient report. So I think it certainly can go either way. But again, if I was a level 4 and I don't know, I haven't looked at the report through the eyes of a level 4 leadership, or thinking that does this present report actually, make sense for me and help me the best that it can. But I'll take a look and try to come up with some ideas that way.
That would be great. Thank you.
Okay, thanks to everyone. Any more comments on the idea of splitting out trauma reports by level of trauma center? Okay, Dr. Bradley, I think we've heard wide support. Do you need any action from this body on this item? I believe you're just looking for general feedback, but I don't want to move on and if there's further need.
Correct. Thank you. Just wanted to get feedback from the group.
Okay. Excellent. If there's, nope, did I hear someone chime in there? Bruce Barnhart made a comment about, I believe, the last agenda item there. Sorry, I missed it. Okay. We'll move on then to the rest of the agenda item. This is a call for agenda items to be considered at the next meeting. Any request for agenda items? Okay. Next then, call to the public. Any members of the public or committee members are welcome to speak. Okay. Hearing none, we'll turn our attention to the upcoming events. There are 3 events, April 5, April 7, and June 9th listed on your agenda. AHLS trainings for the first 2 and an AIMS 22nd Annual EMS Odyssey Conference, all of which will be held virtually. Check out those links on the agenda in your packet today. There is also information on upcoming educational events and conferences on the Bureau's website. Again, you can see those links in your agenda. With that, please note our next meeting will be July 21st, 2020 at 9 a.m. And I do sincerely thank all of you for your participation today. It's been an interesting meeting with great data to review. And with that, we'll adjourn the meeting. Thanks, everybody.
Thank you.
Thanks, everyone.
Thank
Or
you.
take care.
Thank you.
Thank you, Josh. Good meeting.
Thank you.